here at our Victor Campus Center. If you have not been here before, welcome again. And I think Don Amirbar, our Campus Center Director, will make some welcoming remarks.
It's a great proclamation. Just want to thank everybody for coming to the Victor Campus Center. Has anybody not been here before? Oh, excellent. Okay. Got a few.
Would you like to raise our hands facetiously?
Well, welcome. Dr. Sam Samantha, he runs our ICT program, Instrumentation and Control Technologies. Set up this whole presentation tonight with Dr. Peter. Dr. Peter's from FF Thompson Hospital. He's a surgeon, and let Sam go ahead and introduce him. Thanks for coming, and get some pizza when you get a chance.
And there is health food also and water.
And please think of a few questions you might want to ask Dr. Peter when he's done. Okay. Thank you.
So I found some information on Thompson Hospital website about Dr. Peter. By the way, 2 months ago, I first had encounter with Dr. Peters in ER room at Thompson. He operated on my gallbladder, and I say that I'm new and improved Sam 2.0. All right. So Dr. Peter is director of the Robotic Surgery Center for Excellence at the hospital and co-director of Hernia Surgery of Excellence at the Thompson Hospital. He has done robotic and laparoscopic surgery for gallbladder, stump, bowel, and colon surgery. So there are other details. Some of those words I probably will mispronounce, so I will not try. Dr. Peter grew up in India, but then also here in this country, and had earned bachelor's degree in biology at Purdue University in Indiana, and completed MD at Indiana University School of Medicine in Indianapolis, internship and residency in Pittsburgh. So I was in Pittsburgh from 78 to 81 as a graduate student at Carnegie Mellon University.
Okay.
Near there. And Dr. Peter is a friend, co-worker of my primary care physician, Dr. Go. And so they had worked together in Canandaigua Medical Group from 2012 through 18. And prior to that, he had worked in Pittsburgh. So as you would expect, he's fellow of American College of Surgeons and American Board of Surgery. Please give warm welcome to Dr. Peter. He took time out of his busy schedule and family schedule as well to be with us here. Thank you.
So can everybody hear me okay? Well, thank you for having me. I appreciate everybody coming out. I am a general surgeon at Thompson Hospital. So what general surgery largely entails is abdominal surgery. So I wanted to talk to you guys today a little bit about what our advances in our abdominal surgery in this current state. I know some of you are eating food. There's a few surgical pictures. Hopefully nobody's going to get squeamish. Maybe they need a garbage can or something in case. So, like all things, to understand where we are today, our status of surgery today, it's important to understand where we came from. And historically, where we came from is this. Is there a pointer here? No. Anyway, so this is a picture I include in a lot of talks. Basically, this is big, old-fashioned, open abdominal surgery. This, thankfully, I've covered up some of the guts in here for you. This is a ventral hernia repair that we sometimes still have to do today. But this is standard exposure for a big abdominal surgery. So for 100 years plus, this was the standard of care. to get at intra-abdominal organs. The issue with accessing the abdominal cavity is you have to make very large incisions. You have to split muscles, split fascia. It requires prolonged recovery, a number of other factors. And again, until very recently, this was the way we did all surgeries. You can see here, this is an example of a type of surgery where we'd open up everybody. This is actually a trauma operation where there's considerable contamination and organ injury, therefore you have to access everything. There is still a place for open abdominal surgery in this day and age, and trauma is actually one of the big indications. You can see this is how they heal. Big open incisions. This is actually, I think, the record for the number of staples in the abdomen is something like 130 or something. And this is unfortunately some of the wound complications that can occur. People don't heal properly. They can have prolonged wound problems, draining sinuses, that sort of thing. So this is big open abdominal surgery. To understand how we came to where we are today, I want to talk briefly about another surgery, a cholecystectomy. Right? So a cholecystectomy is removal of the gallbladder. And the gallbladder is a humble little organ that sits off the biliary tree. With the source of the biliary tree, basically the liver makes bile, which helps digest fat and proteins. The gallbladder stores the bile and then drains into the main ducts and into the bowel. But basically, the gallbladder just sits there, doesn't do much of anything until it forms stones and becomes a problem. So what it can do is the stones can block. It can actually block the major bile ducts and cause serious problems. So the removal of the gallbladder in years past was done through an open incision. Some of you may know people who had big open incisions for removal. And the problem with this kind of incision, especially, a midline incision actually tends to be better tolerated. A gallbladder, a subcostal incision, is actually a muscle splitting incision. We had to split the rectus abdominis muscle, put it back together. The recovery was weeks and weeks. As you may remember, you may have spent more than a week in the hospital and then weeks and weeks afterwards recovering. And this is actually another section from that, which, again, the bigger the incision, the more the risk of wounds. So in 1882, the first successful open cholecystectomy was performed. This was actually in Germany. And for the next 100 years, that became the standard of care for all types of gallbladder disease. In fact, when I was in training, there were still surgeons pining for the days of open surgery. It was the beginning of the laparoscopic era, and people would often complain about doing laparoscopic surgery. So in the early 80s, Kurt Stem, another German physician, was a gynecologist, he pioneered laparoscopy, little incisions, to do gynecologic procedures. And he did ovary procedures, some cystectomies. He actually even advanced it to the point where he was doing uterine surgeries and that sort of thing. It wasn't well received at all. So his colleagues actually they laughed at him, they maligned his name. He actually had to undergo a brain scan, an x-ray at that time. They were convinced that he was crazy doing surgery through little incisions. Erich Mew, also of Germany, performed the first laparoscopic surgery building the work of Kurt Stem. In 1985, he performed the first successful laparoscopic cholecystectomy. He also was significantly maligned. None of his colleagues trusted him. They said this was, quote, Mickey Mouse surgery. This was not acceptable. In fact, he had good success, but in the subsequent years, one of his patients actually died from this. So they actually convicted him of manslaughter. They tried. Luckily, he was acquitted. But they tried to get him to stop doing this technique. And the reasons are myriad. A lot of it had to do with politics and that sort of thing. But one of the things we find is that surgeons are very resistant to change. We don't like to do things differently if they work. And that was the prevailing thinking of the time, was that, hey, this operation works well, why should we change it? So later in the 80s, Philip Moret in France actually introduced it to the rest of Europe, and it caught on like wildfire. People recognized that smaller incisions led to quicker recoveries and a better outcome. And then it traveled stateside very quickly. So in 1988, in Georgia, the first laparoscopic cholecystectomy was done in this state, in this country. and then quickly became a standard of care because the outcomes were so much better. In the late 80s, there were teaching courses around the country as well. One in Tennessee, there actually was a couple out west that introduced the entire country. Interestingly enough, the first laparoscopic cholecystectomy in the state of New York actually happened at Thompson Hospital. My senior partner, Tom Warmer, and his senior partner at the time went to one of these training courses, convinced the medical group to send him to one of these courses and trained and learned to do it. And they did it. It was sort of, I don't know if you're familiar with Watson and Crick and the discovery of, there was almost that element to it where they beat the university by several weeks. And actually, I think it was 3 weeks for the university and 2 weeks at Highland. So they did the first operation. And at the time, Seymour Schwartz, who was the head of surgery at the university, and this tale may be a little apocryphal, but he said something like, this is an experimental surgery, it should only be done at the universities, and you know, it tends to portray him in a little bit bad light, but honestly, I think what he was trying to do was control the market and make sure it was only at the university and not elsewhere. And even in training, like I said, I heard the old phrase, you know, why should I do surgery through 5 little incisions that I can do through 1 big incision, right? It's extraneous, it's all sorts of unnecessary. But by 1992, the NIH came out with a consensus statement that this was truly the standard of care. And why was it the standard of care? So laparoscopy involves little incisions and instruments, instruments with scissor base that grasp and pull and dissect to achieve the outcome. So this is a comparison of a laparoscopic surgery to an open surgery. So the open cholecystectomy, you see, it's a big muscle splitting incision versus laparoscopy with small ports. We triangulate to the organ and we get it out that way. And this is an example of an intraoperative photo of the liver, the gallbladder, showing the anatomy. And one of the interesting things about this is the reason that it took off so well for this kind of surgery was laparoscopic cholecystectomy was the bread and butter surgery. A cholecystectomy is made to be done in this minimally invasive fashion because if you think about how much tissue you have to go through to get to the liver, especially in more obese folks, you're talking about incisions that are very, very long. Versus with little incisions, we can actually look under the liver and we're seeing all the anatomy, you know, exactly like we need to. And these are the incisions. Basically, very small ports, a quick recovery. So what used to be 1 to 2 weeks in the hospital, 6 to 8 weeks off of work became same-day surgery, and sometimes people go back to work the next day. My nurse had gallbladder surgery on Friday. She was back to work on Monday. I mean, she's a bit of a crazy person. That's a little bit too much, but this is what we do. And now we routinely do gallbladders the same-day surgery. You know, 4 or 5 in a day, and they go home. Improved cosmesis, improved patient satisfaction. Nowadays, if somebody's doing an open cholecystectomy as the first line operation, do not go to that person because that is not the standard of care. So with the advent of laparoscopic surgery, it actually increased the indications that we could do this. So we could do more operations. We could do operations for less urgent, less obvious symptoms. So somebody who we thought had significant symptoms, but it wasn't a life-threatening kind of process. Excuse me one second, get some water. That actually could be more of an indication to do it because the risks were so much lower. So it improved the surgery for which we could do this. So in 1990, 10% of laparoscopic cholecystectomy was performed laparoscopically. By 95, it was 80%. By 2008, it was 90%, and now it's 99.9%. In fact, for laparoscopic surgery, we always start a gallbladder laparoscopically. Sometimes we have to convert, but it's very rare. The vast majority of the time, we do it laparoscopically. And here's an adoption trend. You can see the open line going down, and then the laparoscopic plateauing out. So what did this do? So laparoscopic cholecystectomy opened up the window of what was possible. Right? For the first time, people could see we can do major abdominal surgeries through little incisions. And that led to innovation in the industry. So the industry came on board and brought a whole suite of innovations to help us do these surgeries. So for example, staplers. So endoscopic staplers were fashioned for laparoscopic equipment. If you ever get a chance to read about the history of staplers in this country, it's actually very, very interesting. We stole this technology from the Russians, reverse engineered it, and to get it to work in our system, because they had actually the innovation first, but we had the infrastructure to make it possible and make it widespread. It's actually a very interesting story. We literally sent guys over there. They pretended to be reporters, stole this thing, brought it back, and there's some good books on that. But in any case, the stapler allowed bowel surgery to be done laparoscopically. Various energy instruments allowed us to seal vessels and do more precise dissections. Suturing devices were made possible as well. And this is some other innovations about single site, single incision surgery done laparoscopically. Again, all these things pushed forward by the advent of a laparoscopic cholecystectomy. So here's some examples of some advanced laparoscopic surgery. This is a laparoscopic Roux-en-Y gastric bypass, something that, again, we do now with little incisions routinely. And it's again, very rare for an open Roux-en-Y gastric bypass. In fact, it shouldn't be done. It should be done laparoscopically. This is a liver resection there. That's a hiatal hernia. That's a hernia at the esophagus. So this surgery, we're looking up into the chest. They're pulling the esophagus out of the chest and suturing. Again, surgery that is done because of the technology. This is a laparoscopic spleen, and then this is a bowel anastomosis. So this is a bowel stapler we're using to staple the bowel together. Again, this could not be done without this technology, but it's very commonplace. I think I did 2 of these last week. This is an adrenal surgery, and this is a hernia repair, which is one of the things that's near and dear to my heart. This is a hernia, a hole in the abdominal wall, and this is the mesh that we're using to fix it. So the mesh is, right now it's almost always permanent, right? There is a trend now of biologic products, and eventually, actually, I think we'll be in a full biologic. Right now, the standard of care is a permanent mesh, yes.